Thank you, Professor Moriyasu, for kind introduction, and good evening, ladies and gentlemen. It's a great honor to present our recent work in this conference. I'm going to talk about two things. Firstly, new technologies on April ice feeds, such as shell wave speed, shell wave elastography, and shell wave dispersion imaging, and attenuation imaging. And secondly, clinical trial on non-alcoholic fatty liver disease using the new technologies. Okay, let's start with the first thing. Shell wave elastography measures liver stiffness for measuring shell wave propagation speed, which can assess liver fiber stage, and so we can avoid unnecessary invasive liver biopsy. Here's another feature of shell wave is dispersion. This slide shows the technical background of shell wave dispersion imaging. If tissue was perfect elastic tissue, shell wave speed is constant. In contrast, if tissue is viscoelastic tissue, as the shell wave frequency increases, shell wave speed increases like this. This phenomenon is called shell wave has a dispersion of frequency. In fact, shear elasticity is fixed 2 kilopascal, and the shear viscosity is changing from 0.1 to 0.5 pascal second. The slope increases as the increased level of viscosity. So if we measure the slope, we can assess the degree of viscosity. But please note that dispersion slope is not the viscosity coefficient itself, but correlated to the viscosity coefficient. Shell wave dispersion measures dispersion slope of the shell wave in viscoelastic liver. Dispersion slope is displayed on color map as well as grayscale, elasticity, and fluctuation map like this. Although further research is still needed, but preliminary evidence shows dispersion slope is more sensitive to detect necrotic inflammation than liver stiffness. Here is another feature of ultrasound is attenuation. Quantification on attenuation coefficient can assess liver steatosis grade. And at the bottom, we can see attenuation coefficient and reliability index is shown here. Preliminary evidence shows attenuation coefficient is very useful to assess steatosis grade. So let's move on to the next topic, our experience of clinical trial on non-alcoholic fatty liver disease using the new technologies. Non-alcoholic fatty liver disease is one of the most common chronic liver disease worldwide and strongly associated with metabolic syndrome and obesity. And approximately 20 to 25% of NAFLD patients develop non-alcoholic steatohepatitis, leading to faster fibrosis progression to cirrhosis and hepatocellular carcinoma, which are established risk factor of liver-related deaths. So NASH diagnosis is essential for clinical practice. NASH diagnosis is made histopathologically. NAFLD activity score is used for this purpose. NAFLD score comprises sum of steatosis, inflammation, and necrosis. But fibrosis staging is also important to predict the prognosis of NASH patients. Although liver biopsy is essential, it has many drawbacks, such as high cost, sampling error, and risk of complications. So it is important to determine the non-invasive parameters as surrogate markers of those histologic features. So currently, newly developed 2D shell wave elastography produced by Canon can measure 3 parameters such as shell wave speed, dispersion slope, and attenuation coefficient. So in this time, we hypothesized that measurement of shell wave speed, dispersion slope, and attenuation coefficient may detect liver fibrosis, inflammation, and steatosis respectively in patients with NAFLD, and combination with 3 parameters may improve diagnostic performance for NASH. So the purpose of this study was to investigate the accuracy of shell wave speed, dispersion slope, and attenuation coefficient measurement obtained using a 2-dimensional shell wave elastography in assessing fibrosis, inflammation, steatosis in patients with suspected non-alcoholic fatty liver disease. The study is prospective cross-section study of patients with suspected NAFLD who underwent 2D shell wave elastography with a liver biopsy assessment at the same day. Between April 2017 and March 2019, 120 consecutive adult patients with clinically indication for liver biopsy for suspected NAFLD were consecutively enrolled. The primary outcome of this study was diagnostic accuracy of dispersion slope against histological evaluation of lobar information. And secondary outcomes were development of statistical model of histological NASH prediction using the 3 imaging parameters. And second, diagnostic accuracy of shell wave speed against histological evaluation of fibrosis. And third, diagnostic accuracy of attenuation coefficient against histological evaluation of steatosis. This slide shows inclusion and exclusion criteria of this study. We used Aprio i800 with 3.5 MHz convex array probe. Just before liver biopsy, shell wave examination was performed from right intercostal space and measured 3 use parameters. And we conducted 10 times for shell wave speed and dispersion slope measurement, and 5 times for attenuation coefficient measurement, and record the measurement value and the image data. In this time, IQR per median values of less than 0.3 for shell wave speed measurement and dispersion slope measurement suggest that the dataset may be acceptable. This slide shows shell wave elastography interface. As you can see, shell wave speed, dispersion slope, B mode, and propagation map are shown in the single image. In this study, we placed single 1 centimeter circular region of interest placed on the map throughout the cases. This slide shows attenuation imaging. As you can see, we placed the yellow line on the map. And here shows attenuation coefficient and the reliability index is shown here. These results are shown on the reporting system like this. In histological analysis, liver biopsy was performed with 16 or 80 gauge core biopsy needle and obtained 1 specimen as close to shell wave measurement area as possible. And the NAF reactive score was used to assess steatosis, lobar inflammation, and hepatocellular ballooning. Fibrosis stage was also evaluated. Diagnosis of NASH was made according to the classification by Matteoni. Histological evaluation was performed by a dedicated study pathologist. In statistical analysis, diagnostic accuracy on US parameters was assessed by area under the ROC curve. Correlation between histological feature and US parameters was assessed by multivariable regression analysis. Next, I'll show the results. This shows flow diagram of the study population. We enrolled 120 adult patients with clinical indication for liver biopsy for suspected NAFLD. And we excluded 9 patients. 7 were excluded due to undeniable measurements of dispersion slope. And 1 was reduced due to undeniable measurement of both shear wave speed and dispersion slope. And 1 was also reduced due to another diagnosis. So finally, we enrolled 111 eligible patients in this study. This shows the baseline characteristic of the patient, 57 male, 54 female cases, and mean age was 52 years old, and mean body mass index was 27.2. This shows the distribution of steatosis, lobar affirmation, and ballooning grade. And also, distribution of fibrous stage is shown here. And in this study, NASH accounted for 81% of the study population. This shows the assessment of lobar affirmation using dispersion slope. As you can see, a box plot shows as the lobar affirmation grade increases, dispersion slope increases like this. If we classify lobar information grade 0 vs others, the area under the arrows curve was 0.952. And we classified lobar information grade 0 and 1 vs others, the ALC was 0.806. And when we detect lobar information grade 3, ALC was 0.852. It's a relatively high diagnostic accuracy. And this slide shows the assessment of fibrosis using shear wave speed. As you can see, box plot showed as fibrosis stage increases, shear wave speed increases like this. When we classified fibrosis grade 0 vs others, the ALC was 0.75, and we classified fibrosis grade 0 and 1, and others, ALC was 0.878. And when we diagnosis fibrosis grade 3 and 4, ALC was 0.9, and we detect cirrhosis, ALC was 0.951. This shows the assessment of steatosis using attenuation coefficient. A box plot shows shear wave steatosis grade increases, attenuation coefficient increases. When we classified steatosis grade 0 vs others, the ALC was 0.884, and we classified status grade 0 and 1 and others. ALC was 0.857, and we classified status grade 3, ALC was 0.75. As you can see, attenuation coefficient is useful to detect relatively early stage of steatosis. This shows the diagnostic performance of US parameters for detection of NASH. The ALC for shear wave speed was 0.702, and dispersion slope was 0.756, and attenuation coefficient was 0.75. As you can see, the dispersion slope was the highest, but the diagnostic accuracy is not adequate to discriminate NASH. But all combination of 3 parameters, the diagnostic accuracy was much more improved. ALC was 0.806. This slide shows influence of ultrasound parameters on each histologic parameters. This schematic slide is based on the multiparametric regression analysis. And the shear wave speed was significantly correlated with hepatic fibrosis. And dispersion slope was mostly significantly correlated with hepatic inflammation and partly hepatic steatosis. And attenuation coefficient is mostly significant with hepatic steatosis and partly hepatic inflammation. In summary, on biopsy-proven NAFLD patients, shell wave speed correlated with fibrous stage with relatively high diagnostic accuracy. And the dispersion slope was significantly correlated with low polar information grade with high diagnostic accuracy. And attenuation coefficient was significantly correlated with status grade with relatively high diagnostic accuracy. And all combination of 3 parameters, NASH diagnosis with high diagnostic accuracy. So how to use these new technologies on Apollo Eye for the NAFLD patient? In my view, attenuation imaging is very useful to detect liver steatosis, especially relatively early stage of hepatosteatosis. And shell wave dispersion is also very helpful to differentiate NASH from simple steatosis. And shell wave elastography is also helpful to detect advanced fibrosis and cirrhosis. And if we found liver nodule, contrast enhanced imaging is very helpful to diagnose hepatocellular carcinoma. So Apollo Eye series with liver package is a one-stop shopping for management of patients with NAFLD. So in conclusion, prospective analysis of patients with NAFLD showed attenuation coefficient, dispersion slope, and the shell wave speed was very helpful for assessing liver steatosis, low polar information, and fibrosis, respectively. And Apollo Eye with liver package is a one-stop shopping for management of patients with NAFLD. Thank you for your attention.